This is all over the place. No matter where you go, whether it's Consumer Reports or Forbes or Time, it's all about genetics and genomics and looking at personalized medicine in general. So it's just not limited to us as physicians and providers, but it's out there in the real world. So what I want to do is give a two-part talk. The first is the background to precision medicine, exactly what is precision medicine, and then talk about specific uses for precision medicine. Many of them cross with Dr. Carlson just talked about. So what is precision medicine? So this is a government initiative that started several years ago, and it was called the Personalized Healthcare Initiative, and basically allows doctors and researchers to predict more accurately which treatment and prevention strategies for a particular disease will work, certainly not just for prostate cancer, for all diseases. And again, this is in contrast to the one-size-fits-all approach that has been around with us in medicine for hundreds of years. We're now getting much more refined and figuring out exactly what's the right treatment, the right screening for the right patient at the right time. So if we look at the Personalized Healthcare Initiative and we look at prostate cancer, we're all over the place. Biomarkers, risk prediction, stratification, drug repurposing, diagnosis, et cetera. So we're in prostate cancer and urological oncology, we are thick in the middle of this. So, recently over the last 20 years, looking at what we've been doing, we've had better imaging, better MRI, better ultrasound technologies, and we have moved towards blood, urine, and liquid biopsies. We'll talk about a little bit more. However, when you look at it, we really are doing a much, much deeper dive. We're going beyond histology, and it was mentioned biomarkers, artificial intelligence. We're looking at RNA tumor markers, and we are really looking very closely at the individual genomics and the individual base pairs that may be present in a person's genetic or genomic or somatic tumor. So we're really honing it down to a very, very precise level. So it's hard to believe, but way back in the last century, in 1992, we had the first report from Jefferson looking at what we called hematogenous micrometastasis in prostate cancer. And I have to say, us and groups up in New York and out in Seattle, Washington, we spent the next 10 years trying to figure out exactly what we were doing. The problem is, I think it was like taking a cake out of the oven before it was done. We really didn't have a lot of understanding what was going on. And as the years have gone on now, we know that there's a lot of stuff out in the blood and a lot of things that are helping us with liquid biopsies. There's cell-free DNA, there is exosomes, there's circulating tumor cells and the like. But we have to recognize too that we're on a pathway to making this work. And Dr. Wyatt up in Canada has really shown that there is a very good correlation for advanced prostate cancer. It's not clear that in early disease, this is very useful, liquid biopsy, but certainly for late metastatic castrate-resistant prostate cancer, he has shown a very high concordance with tissue biopsies as well as what you can catch out in the blood. So precision medicine for prostate cancer risk, and again, Sigrid talked a little bit about this. We're getting better, and this is the most recent NCCN guidelines where we're focusing more on family history of cancer, personal history of high germline mutations. We're focusing more on family history beyond prostate cancer. As many of you know, we had a consensus in Philadelphia about 7 or 8 years ago, and from that point forward, it was no longer, oh, does anybody in your family have prostate cancer? You have to start asking about breast cancer, ovarian cancer, endometrial cancer, Lynch syndrome, and the like. So again, we're refining those individuals who may benefit from prostate cancer early detection. And again, certainly the big dog for us in prostate cancer is really the BRCA2 gene and really the understanding. And again, what I always like to point out, breast cancer is decades ahead of us in this area of genetic and genomic testing. But if you also look at it, it's a heck of a lot more prominent in breast cancer than it is prostate cancer. Certainly, prostate cancer risk goes up if people have the mutated BRCA2 or BRCA1 and other genes, but not to the same degree in breast cancer again. But we're getting there. I think we're catching up. We've learned that if you've got a BRCA mutated gene, they have a much worse prognosis. They're much more likely to die from their prostate cancer. This is now getting baked into how we screen and counsel patients for prostate cancer. Sigrid mentioned this area, which is evolving. It's out there. It's not commonly used yet, but I would imagine in the next few years we'll be getting more and more opportunities to look at polygenetic risk scores that not only look at mutated genes, but also look at SNPs, the single nucleotide polymorphisms that give us brown eyes and blue eyes and red hair and brown hair and the like. What about guiding prostate biopsy? Again, Sigrid gave a nice background on this. We have a whole slew of opportunities out there. None has really come to the front, per se, except perhaps the MRI. We have a lot of molecular blood tests. Sigrid talked a little bit about the online calculators that are out there. We have PSA-related blood tests, and we have the whole family of urine-based blood tests. Again, it was pretty amazing that around 1998 or 1999 that we actually had the first report that you could shed prostate cancer cells into the urine, and that's led to a whole expansion of precision medicine and guiding us towards who should have a biopsy and who shouldn't. And again, Sigrid mentioned this very much. I think we all agree that initially when the MRI was out there without the PIRAD scoring system, many of us were a little bit suspect on how good the MRI was at picking up prostate cancer. But clearly, to the credit of the radiology community and really developing the PIRADS version 1 and now the PIRAD version 2, very, very helpful, and in fact has really become something that is in our daily clinical practice in urology. What about precision medicine? What about early treatment versus observation? Well, we have a whole slew of tissue analysis to inform treatment. Several of our colleagues are here today, which will be talking about it from industry. But you have negative biopsy, big attention on active surveillance. We see the series of assays that are out there that predict who will progress or who might die from prostate cancer. So again, this is precision medicine 101 using these, they're really not molecular analysis, but they focus on different aspects of not mutated genes, but looking at different RNA expression, or in the case of the MDX, the methylation pattern. This is something that we were involved with a few years ago when Bobby Den was at Jefferson. We did a study on post-radical prostatectomy looking at the Decipher score. Who needed early radiation? Who could you wait? And again, we showed, and this is baked into our daily practice now too, when we're trying to figure out who needs post-radical prostatectomy radiation early versus late. We rely very heavily on the Decipher score, telling us that if you got a low Decipher score, there's no oncologic benefit from radiation at lower PSAs. However, if you've got a high Decipher score, men has substantial benefit from radiating them at a much longer PSA. And again, this has been baked into our daily practice. Lastly, I think probably one of the biggest areas of massive advance over the last 10 years in prostate cancer is precision medicine and advanced prostate cancer. Colin Pritchard and a team up at Seattle a few years ago published this sentinel paper showing that germline DNA repair mutations were very common in metastatic prostate cancer. And their original study showed the germline mutations were in around 12% of metastatic versus about 5% of localized disease. As the months and years have gone on, that number of germline mutations now is probably closer to 20 to 25% if you look for them. This has been one of the big breakthroughs in somatic testing and testing a whole panel of genes out there and focusing on what's the best treatment for this patient. think everyone knows that you also get from some of the companies a printout of what clinical trials the patient may be eligible for as well. This spectrum of prostate cancer here, going from early disease through the end, you can see out here precision medicine is really found its home with third-line and fourth-line treatments for metastatic castrate-resistant prostate cancer that rely on genetic testing or microsatellite instability or tumor mutational burden. And again, yes, if you think about it, PSMA imaging and Pluvicto and things like that are very, very common. Lastly, Theranostics is part of precision medicine. We know that targeted radioligand therapy with lutetium in men who have a positive PSMA scan. Again, this is precision medicine at its finest. You're not just, we used to use samarium and other agents, just sort of tried them when patients failed everything and wiped out their bone marrow. Well, now we're being very precise on the radioligand targeted therapy. So again, this is a great example of precision medicine going forward. So the evolution of precision medicine has really been very rapid, I think, over the last 10 to 15 years. Imaging, detection methods now allow more focused screening and more diagnostic and treatment approaches. And a lot of this that we're looking at are translational research discoveries. Our PhDs in the lab making discoveries that are then moved forward. I think this is a big advance in our field of medicine. And again, how different trials are now put together. There's basket trials, bucket trials, umbrella trials. An example of a trial is the Leonard G, one that will be looking at Decipher, whether or not to de-escalate radiation therapy and androgen deprivation therapy regimens. And Dr. Andriol, this is for you, your home base here. This is our famous painting that Jefferson sold for $80 million. But if you come by Jefferson, there is a $1 million reproduction that still hangs in our hallway. So even though this is now owned by the Twin Bridges Museum and the National Gallery and it rotates around, we have a 98% Sotheby's reproduction. So it still hangs out in the hallway. And if you come by Jefferson, we'd be happy to show it to you. Again, I appreciate your attention. Thank you very much.